Very good evening to all my dear friends who have joined here through this channel. Once again, I welcome you all for this wonderful session. Today, we are going to have a masterclass in microbiology by Dr. Benedict Vinothini, ma'am. Thank you, ma'am, for joining with us among your busy schedule. So today, we are going to start with the enteric fever, and I hope this will be useful for you all. So now I request ma'am to take over the session.
So good evening, everyone. So today's session will be on enteric fever. Am I audible?
Yes, ma'am.
Yes. So we'll start with the infections of GI tract. So GI tract infections are actually classified into diarrheal diseases and other GI infective syndromes. In diarrheal diseases, we have got diarrhea, which can be either an acute diarrhea or it can be a chronic persistent diarrhea or traveler's diarrhea. And dysentery, we have got amoebic dysentery and bacillary dysentery. And we have also got gastroenteritis and food poisoning. So apart from that, in other GI infective syndromes, we have got necrotizing enterocolitis, necrotizing enteritis, pseudomembranous enterocolitis and peptic ulcer disease, right? So with this broad idea, we'll move to the next. We start with the case scenario, right? A 7-year-old boy was admitted in the pediatric ward with history of remittent fever, which gradually increased over the past 5 days, and he also had abdominal pain, vomiting, diarrhea, and malaise. On examination, there was a rise in temperature of 101.8 degree Fahrenheit, and the heart rate was increased to 92 per minute, and there was pallor, and the tongue was coated, and the abdomen was tender on palpation, and there was mild hepatosplenomegaly. On the laboratory findings, we have got leukopenia, eosinopenia, and the WIDAL test was negative, MPMF was negative, and the dengue NS1 IgM and IgG was also negative. And blood culture was sent, and the reports are awaited. So with this, what would be your diagnosis? Can anyone answer? Yes, today's class is about enteric fever, so obviously this is going to be an enteric fever case. So what are the points which are favoring towards this enteric fever? The one is remittent fever. The other one, there is patient has got vomiting, diarrhea, and the temperature is raised, and there is increase in heart rate, but that is not actually related to the temperature. That we call it as relative bradycardia. This is very important finding here. It's relative bradycardia, right? Yes. So and the other one feature is mild hepatosplenomegaly. So there is infection in the GI tract, and also the reticuloendothelial system is also involved, right? Yes. So in this laboratory findings, the very important thing here you have to note here is eosinopenia. Eosinopenia is very indicative of typhoid fever. So the diagnosis is going to be typhoid fever, and what would be the empirical treatment is actually the empirical treatment, it can be either ceftriaxone or it can be ampicillin also can be given, or azithromycin. So the main drug of choice could be ceftriaxone or azithromycin. So I'll move on to the theory part now. Enteric fever. So enteric means intestine, right? Though the name is actually indicates that it's an intestinal infection. So it is actually a multi-system disorder or systemic infection, or it is a bloodstream infection, which is caused by Salmonella typhi, Salmonella paratyphi A, B, and C. So here you have to note one thing is, right, this typhi, it is actually a serotype and it is not a genus name, and that is why it is written in capital letter, right? So you must remember this Salmonella typhi. This typhi is actually the name of a serotype. And coming to the general characteristics of Salmonella, so Salmonella belong to the family Enterobacteriaceae. As you all know, the Enterobacteriaceae family consists of E. coli, Klebsiella, Salmonella, Citrobacter, and all these organisms. And the general characteristics of the Enterobacteriaceae is included for Salmonella also. And therefore, this is an aerobic organism and also a facultatively anaerobic organism. What does this mean? Aerobic organism, so it can grow in the presence of oxygen, and it can also survive in the absence of oxygen. That is why you call it as an facultatively anaerobic organism. And here you see, this is the organism, and here you have got some thread-like structures. What that is the flagella. So it is around the entire organism, so it is a peritrichous flagella. The other features of the Enterobacteriaceae are their oxidase negative, catalase positive, and the nitrate reduction test is positive. So all these are features of Enterobacteriaceae. Apart from that, one specific feature for Salmonella is they are NLF or non-lactose fermenters. So these are the general characteristics of Salmonella. And coming to the classification, it is classified according to the clinical basis or antigenic characteristics or molecular characteristics. So according to the clinical features, it is classified into typhoidal salmonella, and non-typhoidal salmonella. So anything which is causing typhoid, you call it as typhoidal salmonella. So we have already seen in the first slide. So typhoidal salmonella includes Salmonella typhi, Salmonella paratyphi A, B, and C. Among this, Salmonella typhi is the most common, followed by Salmonella paratyphi A and paratyphi B. Salmonella paratyphi C is not reported in India. Yes. So coming to the antigenic classification, so it is also called as the Kaufman-White classification. Here, the antigens in this Salmonella is H antigen, O antigen, and VI antigen. So VI antigen is a polysaccharide antigen or the capsular polysaccharide, and O antigen is a somatic antigen, and the H antigen is the flagellar antigen. So according to this antigens, it is further classified into many serogroups A, B, C, D, and E. And this A serogroup consists of Salmonella paratyphi A, and B consists of para B, and C consists of paratyphi C and cholera suis, and D consists of Salmonella typhi, and E consists of this anatom group. Yes. So among this, so now we'll see only the Salmonella typhi and Salmonella cholera suis. The other one is Salmonella Dublin. So all these have got capsules. So what does it mean by it has got capsule? So this VI polysaccharide will be present only in these three species, typhi, cholera suis, and Dublin. Right. So all of this do not have this VI antigen. Coming to the O antigen, it is represented as numbers. So Salmonella paratyphi A, it has got 1, 4, 1, 2, and 12. And paratyphi B, it has got 1, 4, 5, and 12. And typhi, it has got 9 and 12. You people do not want to memorize these numbers. I just wanted to let you know one thing. This factor 12 is actually present in paratyphi A, paratyphi B, and typhi. So that is the one thing which you have to remember. So because of this, the antibodies which are produced against Salmonella typhi, the O antibodies which are produced against the Salmonella typhi will cross-react with paratyphi A and paratyphi B. That is the one reason we are using only the O antigen of Salmonella typhi in WIDAL test and not the O antigens from paratyphi B and also paratyphi A. So the next one is the H antigen. It is a flagellar antigen. In this, it is represented as letters. So para A has got flagella A, then B has got B, and C has got C. And in typhi, the flagella is labeled as D, right? So this is the flagellar antigen. So one species, Gallinarum, is one non-motile species, belongs to the D group. So D group has got typhi, Dublin, and Gallinarum. One feature of Dublin is it is capsulated and VI antigen is present, and the other one is Gallinarum, which is a non-motile species, right? So this is about the antigenic classification. So this antigenic representation of Salmonella typhi will be like the O antigen is 9, 12, and the H antigen is D, and there is also VI polysaccharide. So this will be the antigenic classification of Salmonella typhi. Now coming to the molecular classification, according to the DNA hybridization studies, it is being classified into two species, the Salmonella enterica and Salmonella bungorii, right? This molecular classification based upon the DNA hybridization studies, it is divided into two species. One is enterica, the other one is bungorii. So Salmonella enterica is further subdivided into six subspecies, which consists of enterica, salami, and others. Right? In this, you just remember this subspecies enterica, and therefore the Salmonella typhi, the full name will be Salmonella enterica, subspecies enterica, and serotype is typhi. Now you know that the species name is enterica and the serotype name is typhi. Just because this is the serotype name, it is written with a capital letter. So we'll move on to the next, epidemiology. Yes. So in India, Bhutan, and all these blue colored regions, so it is very common or endemic. And here in this place, Australia, and here in North America, it is not present. Rest of the species, there is some medium prevalence. Coming to the host, so humans are the only host. There is no animal reservoir. Humans are the only host. Coming to the carriers, so what do you mean by carrier? So any person who is carrying the bacilli for a long time and transmitting the infection, you call them as carriers, because they are excreting in their secretions, in their fecal material or in their urine, and therefore you will be spreading the infection very rapidly, and you call them as carriers. These carriers can be either convalescent carriers, temporary carriers, or chronic carriers. In convalescent carriers, like from the 3 weeks of infection to up to 3 months, if they are transmitting the infection or shedding the organism, you call it as a convalescent carriers. So temporary carriers from 3 months to 1 year, you call it as temporary carriers. If they are shedding for more than 1 year, you call it as chronic carriers. So from this carrier state, so speaking about this carrier state, we cannot forget one term, typhoid Mary. Typhoid Mary is actually a New York cook was actually spreading the infection unknowingly. So the persons are coming to her and they're eating the food made by her. They are actually getting positive for typhoid. And once there is an outbreak, she will leave that place. She'll go to another place and she'll start cooking there. And again, she'll produce an outbreak there. And again, she will leave that place. So, and that was actually continuing. And after a period of time, she has been traced and she was found out to have the infection, and finally she was quarantined for almost 30 years till her death. So that is about the story of typhoid Mary, or the chronic carrier Mary Mellon. Yes, so with this we'll move on to the antigenic structure. So we have seen already that three antigens are present. One is the capsular antigen. Usually the capsular antigen will be labeled as K, but here it was initially thought as a virulence factor, and it is also a virulence factor since it will inhibit the phagocytosis. So because of that, it is indicated as VI, and the flagellar antigen is the H antigen, and the somatic antigen is the O antigen. So we have already classified this in the initial part. Now we'll see each in detail. The somatic antigen or the O antigen, it is present in the cell wall, that is the lipopolysaccharide antigen. And the flagellar antigen, it consists of the protein flagellum. And the capsular antigen, it consists of a polysaccharide. Would have been learned in your immunology part, anything which contains protein or more immunogenic, followed by polysaccharides, carbohydrates, and then followed by lipids and nucleic acids. So here the protein part is present in the flagella, the protein flagellin, and therefore it is more immunogenic. And the somatic antigen, it contains a lipopolysaccharide, and that is less immunogenic. Capsular antigen, that is also a polysaccharide, so it is less immunogenic. And it is a T cell independent antigen. Anything which is T cell independent, it is going to be least immunogenic. So the coming to the characteristics, they are heat stable. The O antigen is heat stable and alcohol stable. The H antigen is heat labile and alcohol labile, and capsular antigen is heat labile and alcohol stable. This is mainly important for the preparation of antigens for WIDAL test. So whenever a foreign antigen will enter into your body, it will produce some antibodies. So all these antigens will produce respective antibodies. This O antibody is the one which will appear early and disappear early. So once you detect an O antigen in the WIDAL test, it will indicate a recent infection. This H antibody, it will appear late, and that also will disappear late. So if this H antigen alone is present in the absence of O antibody, then it will represent a convalescent stage. And this capsular antigen or the VA antigen, it will disappear early in the convalescent stage. If at all it is persisting, it indicates carrier state. So this is about the antigenic structure. So the outer part, it is the VA antigen, and then within that you have got the lipopolysaccharide or the O antigen, and this flagella or the flagellin protein that indicates the H antigen. This is about the antigenic structure. So with this, now we'll move on to the pathogenesis. So what is the route of transmission of this? So we all know this is fecal-oral route of transmission. So and the infective dose here, it is 10 power 3 to 10 power 6 bacilli has to be present so that it can produce an effective pathogenesis. So if the infected dose is very less, it will be actually diluted or it will be killed by the gastric acid, and therefore it cannot produce any infection. And the incubation period is usually 10 to 14 days, but it may vary as much as 5 days to 21 days. So once this organism is entering into your oral cavity, it will reach the stomach, and it has to overcome the gastric acidity, and after that it will reach the duodenum and finally the ileum. So that is a small intestine. Here you have got the Peyer's patches. So these Peyer's patches are the lymphoid follicles, and they have got one cells called as the M cells or the microfold cells, the phagocytic microfold cells. This organism Salmonella, which will stimulate the production of membrane ruffles in the M cells. Then therefore some membrane ruffles will be produced, and therefore it will attract the Salmonella antigen here, and with the help of the bacterial type 3 secretion system, it will be internalized. And so it is called as bacteria mediated endocytosis. And this M cells then will help in the traveling of the bacteria from the mucosa to the submucosa. This is the submucosal layer, and inside the submucosal layer you have got the macrophages, and that will take up the organism. So once inside the macrophages, what is the action of the macrophage? The macrophage has to kill the bacteria by the phagolysosome fusion. But this organism, because of the quarant sensing mechanism or the FOQ mechanism, that is like quarant sensing is like it is some interaction between the bacterial organism, you call it as quarant sensing. It is just a communication system, you call it as a quarant sensing. Because of this quarant sensing, it will produce some antigenic changes in the lipopolysaccharide, and therefore this macrophages will not be able to kill the bacteria. So that is for the intercellular survival inside the macrophages, this quarant sensing will be helpful. So now we have learned, so the M cells will take up and it will go through the mucosa to the submucosa where it will present to the macrophages, and this macrophages will actually, instead of killing, it will actually promote the organism's growth because of the quarant sensing mechanism. Hope you all understood this. Yes, so now it is inside the Peyer's patches, which is full of lymphoid follicles, and from the lymphoid follicles through the lymphatics, it is going to reach through the bloodstream, that is the primary bacteremia. So since it is in the bloodstream, now it is going to go to all the organs, particularly the reticuloendothelial system, which includes the spleen, liver, bone marrow, and also it will go to the other organs like lungs, gallbladder, kidney also. And it will multiply there, and from there it is going to come out to the blood again, that we call it as the secondary bacteremia. So this is about the pathogenesis. So we have already discussed, yes, this is the M cells which will take up the organism first, that is the immune sensing cells, and it will take up the organism, and then through the travel to the submucosa where it will present to the macrophages, then it will multiply inside the macrophages, and it will reach the lymph node. So it will reach the lymph node, and again through the bloodstream it is going to go to the reticuloendothelial systems like spleen, liver, bone marrow, and everything. And then again it is going to multiply there, and again through the bloodstream it is going to go to the other organs also. So once this organism is continuously multiplying in the intestine and the Peyer's patches, it is going to produce some infection, inflammation, and necrosis, and therefore it will lead to the production of typhoid ulcer, which is typically an oval shaped ulcer, which is longitudinal to the axis of the intestine. Typical oval ulcer is of typhoidal ulcer. So coming to the clinical manifestations, yes, so we are seeing so many images here. The first one is like the fever pattern. We have already discussed in the case scenario, it is a remittent fever. So what do you mean by remittent fever? Remittent fever is nothing but the fever will be increasing and will never touches the baseline. So there will be more than 1 degree Celsius increase in the temperature in a period of 24 hours, and it will again come down, but it will never touches the baseline. That is called as remittent fever. In that, the subtype, you call it as the stepladder pattern of fever, which is very, very peculiar of typhoid fever. Stepladder is nothing but it will increase and it will remain stable for some period. Again, it will increase and it will remain stable. So, therefore, it will produce a step-like pattern. So, we call it as stepladder type of fever. So, for anybody who is getting an infection is going to present with fever. Whenever there is fever, the patient has to present with tachycardia. So that is the dictum. So fever will always lead to tachycardia. So there is one rule called as Weber-Meester's rule. Weber-Meester's rule. This Weber-Meester's rule says that, so whenever there is increase in temperature by 1 degree Fahrenheit, the heart rate has to be increased by 8 to 10 beats. So here in our case, we saw that the temperature was around 101.8, but the pulse rate was around 94. So that it actually doesn't meet this criteria. That is why we call it as a relative bradycardia. Though this 94 seems to be a bit of increase in heart rate, it doesn't meet the actual Weber-Meester rules of 8 heart rate increase per 1 degree Fahrenheit temperature increase. So that is why we call it as relative bradycardia. And this relative bradycardia is called as Faggot sign. So this is one important MCQ, Faggot sign or relative bradycardia. You also call it as spigmothermic dissociation. So there is a dissociation between the temperature and pulse rate. So that is spigmothermic dissociation. And usually this Faggot sign is seen with typhoid, typhus fever, and also you can see with legionellosis and yellow fever also. So this is one important feature of typhoid. So now coming to the next image, what is this? This pink color rashes, this is a maculopapular rashes or rose spots. So this rose spot or maculopapular rash, actually we cannot see in our Indian population because of the dark skin, but this is also a feature of typhoid fever. And here what you see this is hepatosplenomegaly. So hepatosplenomegaly, because of the involvement of the reticuloendothelial system, hepatosplenomegaly will be there. So fever with hepatosplenomegaly, it can be either typhoid or malaria, or it can be also visceral leishmaniasis. So we have to see for relative bradycardia, we have to see for the stepladder pattern of fever, we have to see for the altered bowel habits. If we are having this mixture of symptoms, then you can label it as typhoid fever. So what do you mean by altered bowel habits? Usually the patient will have constipation for a time and then he will go for diarrhea. Again he will have constipation. So that feature call it as altered bowel habits. So whenever the patient is presenting with fever with diarrhea, you have to ask for another symptom he or she is having altered bowel habits. So that is one important feature to differentiate typhoid from other fevers. This is about the clinical manifestation. So we have already seen remittent fever or stepladder pattern of fever, relative bradycardia, constipation, and followed by diarrhea, what you call it as altered bowel habits, and rose spots. Apart from that, the patient might also have malaise, headache, anorexia. All these are general symptoms. Coming to the complications. So the most common complication will be the ileal perforation or the colonic perforation. Yes, once there is continuous ulcer and necrosis, the patient will go for perforation. So perforation is the most common complication which will occur in the end of the third week. So other complications might be psychosis, meningitis, pneumonitis, pericarditis, or endotoxic shock. So this is the typical perforation. So the ulcer what we saw is an oval ulcer, and the particular, this is the complicated perforation. So with this, we'll move on to the laboratory diagnosis. For whenever you're suspecting a patient with typhoid, what are the samples you can collect? You can either collect blood for culture, or you can collect stool for culture, or we can collect blood sample and we can do serology like viral agglutination, or we can collect a bone marrow aspirate. But there is some timeline there. So when the patient is presenting with less than 5 days of fever, what you are supposed to do is, you are supposed to do a blood culture, because at that time the antibodies will not be produced and the antigen will be present in a high load, and therefore the blood culture will be positive. So at the first week the blood culture will be above around 90% positive, and then again in the second week it will be reduced to 75%, and in the third week it will be reduced to 60%, and the subsequent weeks it will be less than 25%. So ideally the blood has to be cultured in the first week of fever. So in the second week, when the antibodies are produced, we can go for WIDAL agglutination test or the serological test. And in the third week or the fourth week, or if the patient is a carrier, you want to determine the carrier state, what you can do is a fecal culture. Coming to the blood culture, yes. So we are going to collect blood in a strict aseptic precautions, and you cannot directly transport the blood to the laboratory. So you are supposed to put it in a culture medium, what you call it as a BHI medium or the BHI broth. The first picture, this is a BHI broth. It has got only the broth phase, and therefore you call it as a monophasic medium. It has got only one phase, so we call it as monophasic medium. And this one, this is a biphasic medium. You have got a BHI broth, along with it you have got a BHI agar slant here. So we call it as a biphasic medium. It is also called as the Castineira's medium. So one important feature of this Castineira's medium or the biphasic medium is that it has got an agar slope, and therefore once you find turbidity here, you can just tilt the broth so that the subculture will be done automatically. Whereas this monophasic medium, you have to open the bottle, you have to subculture onto an agar plate, so that to identify the organism. And therefore in this biphasic medium, the contamination rate will be very low. This is an automated blood culture bottle here. So there is some automated blood cultures like Bactec system or Bacterialert. There we use this automated blood culture bottles. Once it has been subcultured, you will see the common media what are going to use is McConkie agar or the MAC agar. McConkie agar, here it is a non-lactose fermenting colonies, which you have to remember. So the main purpose of this McConkie agar is to differentiate the organism into lactose fermenting colonies and non-lactose fermenting colonies. Here, if at all it is a lactose fermenting colonies, the entire media will be converted into pink color. Since there is no pink color here, so it is pale colonies, you call it as a non-lactose fermenting colonies. Once it is subculture, now we are going for gram staining, and the gram staining is, here what you are going to see is a gram negative bacilli. So the entire Enterobacteriaceae family is going to be a gram negative bacilli. So coming to the stool culture, yes, the stool culture in the fecal material, you can see so many commensals there, and therefore we have to use some selective medium. So what we are saying here is the DCA medium and the XLD medium. DCA is deoxycholate citrate agar and XLD is xylose lysine deoxycholate agar. So here we have got one substance called as deoxycholate, which is also called as the bile salt. It will inhibit the commensal organisms. So because of this only we are using this selective media to for stool cultures. But in blood usually we do not have any commensal organisms. Anything which is present is a pathogen, and therefore we do not need any selective media. Yes. The first one is deoxycholate citrate agar. You are seeing some pale colonies, and along with it there are some black center. So why do we get this black center? So we are having iron in this medium, and this iron will react with the hydrogen sulfide produced by the organism to produce black color. And the same XLD agar, here also this it contains iron. This iron will react with the hydrogen sulfide produced by the organism to produce this black color. So what are the other cultures we can do? We can take a bone marrow aspirate and culture it, or you can take a duodenal aspirate, or you can do an urine culture for carrier state, or also you can do for clot culture. As a bone marrow aspirate, one specific thing is that even if the patient is on antibiotics for up to 5 days, you can actually get a positive culture. But the blood culture, if the patient is on antibiotics, you may not get a positive test. So bone marrow aspirate, even with 5 days of antibiotics, it will be positive. But one thing is like it is very painful, it is very tedious process, and the patient may not be liking it, and even the clinician will not be the clinician has to be well trained so that he has to do this bone marrow aspirate. Duodenal aspirate, just like the string test you do for giardia, you can collect the sample as a duodenal aspirate and you can culture it. Clot culture, you can you collect the blood and put it in a bottle without EDTA sterile container, and therefore the blood will clot, and you can take the serum and use it for WIDAL test, and this clot you can use for subculturing for this organism. Urine culture for carrier state. So once you have cultured it, you have to identify the organism. The identification you can do with either biochemical test, or you can do a Ramalditov for rapid identification. So Ramalditov is a nanotechnology used for rapid identification. And finally, once you have confirmed, you have to confirm it with serotyping. Serotyping is nothing but you're adding the colony to the anti-sera and you're looking for agglutination. If it is agglutinating with typhoid and salmonella typhi and antigen, it is going to be salmonella typhi anti-sera, it is going to be a salmonella typhi. If it is with paratyphi A anti-sera, it is agglutinating with it, so we call it as a salmonella paratyphi. So serotyping is for confirmation finally. Yes. Coming to the biochemical reactions, I think this you have would have been discussed in the general part. So the first one is the indole test. So it is just a revision of the biochemical reactions here. The indole test positive will be pink in color and the negative it is colorless. Citrate positive will be blue in color and the negative is going to be green in color. So this is the citrate test. This is the indole test, and this is the urease test. The positive test will be pink in color and the negative test will be colorless. And this is the TSI medium. So in TSI, what are the things you are going to see? You have got a butt and a slant. So you are going to see the acid production. If it is entirely it is acid, you call it as A by A. So acid production, whenever there is acid production, there will be change in pH, and therefore this it will change into yellow in color. So when once the entire tube is going to be yellow, you are labeling it as A by A. Here the upper part is the slant is alkaline and the butt is acidic. So pink and yellow, you call it as K by A. And here something that is called some black color is seen. That is because of the production of H2S. And this TSA medium has got iron that will react with the H2S to produce ferrous sulfide that will give this black color. So you write this as K by A with speck of H2S. This H2S is not present entirely. It is present only small amount. So you call it as K by A with speck of H2S. The one main thing here is this does it does not produce any gas. So we call it as an anaerogenic organism, does not produce any gas. So salmonella typhi does not produce gas, so we call it as anaerogenic organism. So this is salmonella typhi, this is salmonella para A, and this is salmonella para B. So para typhi A does not produce H2S, and therefore there will be no black color. Salmonella para typhi B, it will produce abundant H2S. Right? So coming to the indole reaction, for all the three species, so salmonella typhi, para A and salmonella para B. So indole is going to be negative. Citrate is negative for typhi and paratyphi A, but it is positive for paratyphi B. Urease, again, it is negative for all the three species. TSA we have already discussed. Here for Salmonella typhi, it is going to be K by A with speck of H2S, and Salmonella para A, it is going to be K by A without H2S, gas might be present. Para B, K by A with abundant H2S. This is about the biochemical reactions. So this part will be helpful for your practical examinations more than your theory exam. So you remember this paratype B, everything will be positive. So citrate will be positive, and also there will be abundant H2S. And there are some sugars you can do, that is xylose and arabinose. The xylose test, it will be positive for Salmonella typhi, it will be negative for para A, and it will again be positive for para B. Arabinose, here it is negative for typhi, positive for para A, and positive for para B. So citrate is positive, xylose is positive, arabinose is positive. So all this will be positive for Salmonella paratyphi B. Whereas Salmonella typhi, almost everything will be negative except for xylose. So this is about the biochemical reaction. So at least if you cannot remember all these, just remember this TSA, which is very, very important. Indole is negative for everything. Urease is negative for all the three species. Citrate is positive only for paratyphi B. And this K by A with speck of H2S for typhi, K by A with abundant H2S for para B, and without H2S for para A. So just remember this TSI at least. Coming to the antimicrobial susceptibilities, once you have confirmed the organism with serotyping, you have to do antimicrobial susceptibility test so that the patient could be treated appropriately. The test what we are going to do is Kirby-Boyer disc diffusion test. You are going to put a lawn culture of the organism and you are going to place the antibiotic disc, and after 24 hours you are going to see for if there is any clearance or zone of clearance is present, that will indicate a sensitive test. So once the antibiotic is sensitive, that can be used for treatment purpose. If it is resistant, you cannot use that for treatment. This is the Kirby-Boyer disc diffusion test, which you have to do it manually. There is another one technique called as WIDAL, which we can do automated. It is a semi-automated method. So with this, we are finishing the culture techniques. So culture always has to be followed by antimicrobial susceptibility test or a Kirby-Boyer disc diffusion test. Yes. So now coming to the serology. So we have already discussed serology. It has to be done when the patient is presenting with fever for more than 5 days. So after 5 days only antibodies will be produced, and therefore after 5 days only we can do this WIDAL test. So WIDAL is a type of tube agglutination test. So we have got a test tube here, and we will do serial dilutions of the antibody, serial dilution of the patient's serum. So the patient's serum will have the antibodies which will be serially diluted. So in the first tube, we are going to add normal saline, and also you are going to add the patient serum. So it will be already diluted. So and from this part, you are going to add it here, and again you are going to add some more amount of normal saline. So again it will be diluted more. And from this part you are going to add the diluted serum, and again to this you are going to add normal saline. So again it will be diluted. In such a way you are going to do a serial dilution. So once you have made the serial dilution of the patient serum, now we are going to add the antigen. So we will be actually having 4 set of tubes. The first tube is for O, and the second tube is for H, and then the third and fourth for AH and BH. So we are going to add the appropriate antigen. The first set of tubes, you are going to add the O antigen. Second set of tubes, you are going to add the H antigen. In the third and fourth tubes, AH and BH antigen you are going to add. So this particular antigen will actually react with the antibodies if at all it is present. So once it is reacting with the antibody, so what will happen? The antigen antibody will react to produce agglutination. So how will you observe for agglutination? So this O antibody will agglutinate to produce a compact disc-like pattern, and this H antibody will produce a fluffy cotton woolly pattern. So O antibody will produce a compact pattern, and H antibody will produce a fluffy pattern. So wherever you are seeing this compact disc-like pattern, you will take it as positive. So you are seeing here this, it is present till 1:160. So even in 320, 640, there is something is present, that is actually the antigen which has been deposited, and it is not the agglutination actually. So this you call it as button formation. So button formation is always negative. So this is the thing which is positive. So the compact disc-like pattern is positive. So it is positive at a titer of 1:160. So in H fluffy pattern, it is seen till 1:320. Here it is again negative. So there is something called as significant titer. So significant titer. So you imagine a case. So this is positive, O is positive in 1 in 20 and H is positive again in 1 in 40. So can you report it as a positive test? No, because we are living in an endemic area where this antibodies, a mild amount of antibodies will be produced in almost all the people who are residing in that area. Therefore, we cannot take it as positive. Though we are able to see some amount of agglutination, we cannot take it as a significant titer. So significant titer for O antibody is 1 in 80 and H is 1 in 160. So these are things you must remember. So WIDAL test is a type of tube agglutination test which you have to remember. So example for tube agglutination test is WIDAL, and the significant titer for O is 1 is to 80 and significant titer for H is 1 in 160, and the O antibodies will produce a compact pattern and the H antibodies will produce a fluffy pattern. So these are all the things which you have to remember. Now coming, so this is the, when you look into a concave mirror, this is the pattern actually you will be seeing. So coming to the interpretation of the WIDAL test. So just taking for Salmonella typhi, if it is positive for Salmonella, typhi O and TH antibody, then that is positive for Salmonella typhi. So if there is a rise of TO titer, so rise doesn't mean that 1 is to 20 or 40, the O it has to be 1 is to 80 and H is 1 in 160. Then only you can take it as positive. So if there is a rise of TO antibody and AH antibody, that is positive for paratyphi A. If it is TO and BH antibody is raised, then that is positive for paratyphi B. So we have already discussed in the initial part. So only we use only the O antigen of Salmonella typhi. We do not take it from Salmonella para A and para B because of the common factor 12, right? Hope you guys remember this factor 12 is a common antigen which is present in typhoid, Salmonella typhi, paratyphi A and paratyphi B, and this will produce a cross-reacting antibodies. So if there is only rise of TO antibody, there is only the O antibody is raised, the H is not raised. So what it could be? It could be the most commonly it could be a recent infection, because we have already learned the O antigen will appear early and disappear early, whereas this H antibody it will appear at a later stage only. Therefore, the presence of O antibody alone it indicates a recent infection. If there is rise of only H antibody, what will happen? If there is a rise of H antibody, it can be either a convalescent stage, the patient is in a recovery stage, or it can be also an anamnestic response. So what do you mean by an anamnestic response? The patient is actually having an unrelated fever. It can be a viral fever, dengue viral fever, or it can be malarial fever, or any other bacterial illness, and the patient had already previously had some typhoid-like illness. So the patient had typhoid in the past, and now she is having some malaria, and at that time also because of the polyclonal B cell activation. Because of the polyclonal B cell activation, some antibodies will be produced, and these antibodies will cross-react to produce a positive titer for TH antibody. So at that time, we'll call this an anamnestic response. So always this anamnestic response, it will be 1 is to 40 or 1 is to 21. It will be never be a significant titer. So what can we do that? How will you be able to rectify it? Now we can actually ask the patient to repeat the sample. So once the patient is repeating a sample after 1 week, if there is an increase in titer by 4-fold, we take it as a positive test and you will rule out the anamnestic response. If there is no 4-fold rise in titer, and now it is going to be an anamnestic response. Coming to the next one, the rise of all the three antibodies, TH, TAH and TBH antibodies. So if there is a rise in all the three antibodies, it is because of TAB vaccination. So TAB vaccination is obsolete now. So this scenario only is obsolete. So if the patient has taken this TAB vaccination, there will be rise of typhoid and typhi antibodies, AH and also BH antibodies. Right? This is about the interpretation of WIDAL test. So coming to the next one, which is TYPHIDOT. TYPHIDOT is actually a immunochromatographic test or a lateral flow assay. Here it'll have a card. Here this will be the sample window, and here this is the test line. We have got IgM and IgG, and there will also be a control line. So if the patient is positive or negative, whatever it is, this control line has to be positive. But if the patient has got a real infection, either IgM or IgG or both IgM and IgG lines will be positive. If only IgM is positive, it is going to be a early acute infection. If it is like G only is positive, it is always a past infection. We have already discussed. So IgM is for recent infection and IgG is for past infection. If it is both the antibodies are raised, it is going to be an acute enteric fever. This TYPHIDOT is a immunochromatography test or lateral flow assay where you can detect IgM and IgG antibodies separately. Coming to the other investigations, we can demonstrate the antigens with the help of ELISA or counter immunoelectrophoresis. Or molecular methods, PCR, usually you can detect the flagellin gene or IROB, whatever that. So some specific gene for the organism you can detect with the help of this PCR. Non-specific tests, usually you detect for in the total leukocyte count there will be leukopenia and also there will be eosinopenia. So eosinopenia is one very important thing which you have to remember. So eosinopenia always correlates with Salmonella typhi infection. And there will be also, because of the liver involvement, there will be some deranged liver enzymes will also be present. So this is about the investigation part, right? So hope you guys can remember this. So investigations, so one is blood culture, then we'll go for WIDAL. The other is the immunochromatography test, what we have discussed. So apart from that, we can also culture stool or urine or bone marrow aspirate, whatever it is. So all these are about the investigation part, right? Cultures that is, we have discussed in detail. So culture has always to be done with followed by AST test or KB Boyle disk diffusion test. Yes. So I'll move on to the next, detection of carriers. We are going to detect the carrier state. So how can you detect a carrier? So carrier state detection is very, very important. So since we already discussed the story of Mary Malone, so whenever there is a carrier state, if he or she is not getting treated, they will actually be transmitting the infection to a large number of population, creating an outbreak or epidemic, and therefore it is very important to detect the carrier and treat the carriers. So for detection of the carriers, what we can do is you can take culture. You can collect the stool sample or the urine sample and you can go for a culture. Stool culture we have already discussed. We have to culture it in a selective medium, either DCA or XLD. We cannot do it in a low selective medium like McConkey agar. So we cannot culture in a low selective medium like McConkey agar, because since this McConkey agar is a low selective medium, it will not actually prevent the commensal overgrowth, and therefore we have to use DCA and XLD. And the detection of VA antibodies, it is again a tube agglutination test. The titer of 1:10 will be taken as positive. The strain we are using here for the detection of VA antibodies is the Bartnagar strains. So the antigens from this Bartnagar strains will react with this VA antibodies to produce an agglutination, and the titer of 1:10 is taken as positive. And the third method what we can do is isolation from sewage. So you can actually filter the sewage water through a millipore, and this filtered paper you can use for culture. The medium what we are going to use here is Wilson Blair medium. This is a highly selective medium. It is very, very selective, more than DCA and XLD. Therefore, we are supposed to use this Wilson Blair medium only for the detection of carrier states from the sewage. So sewage is supposed to contain almost all the organisms in the world. It might contain anything and everything, and therefore we are supposed to use a highly selective medium. What is the Wilson Blair medium? Okay, this is about the detection of carrier state. So coming to the treatment part, as clinicians, as doctors, we must actually know the treatment part in detail. So whenever you are suspecting a patient with typhoid, what will be the treatment? So we have already discussed with the case scenario. It can be either ceftriaxone or azithromycin. Yes. So ceftriaxone, the dose is going to be 1 gram IV BD. And azithro is 500 mg OD. So azithro are going to give for 5 days and ceftriaxone are going to give for 7 to 10 days. This will be the empirical treatment. So empirical treatment, ceftriaxone or azithromycin. Azithromycin is an oral drug, whereas ceftriaxone I have to give it intravenously. Ceftriaxone we can also give it as outpatient antibiotic therapy or OPAT. So the patient can come in the morning, get the dose of ceftriaxone, again go home, again come back and get that. So that you call it as an outpatient antibiotic therapy. That one thing which is ceftriaxone, we have to give it 1 gram IV BD. So whenever there is a fully susceptible range, we have already discussed, whenever you have cultured, it has to be followed by a antibiotic sensitivity test. So if the organism is sensitive for all the drugs we tested, we call it as a fully susceptible organism. When the organism is fully susceptible, the drug of choice will be ciprofloxacin. Just remember the drug of choice will be ciprofloxacin 500 mg BD for 5 days. This will be the drug of choice. If at all you do not know the sensitivity pattern, at that time you can start Ceftria or Acitro. Once you know the sensitivity pattern and the organism is susceptible to fluoroquinolone, the drug of choice is always going to be ciprofloxacin because the than 2% with ciprofloxacin, whereas the carrier rate is actually the carrier rate is a little bit higher with ceftriaxone and azithromycin, and therefore the drug of choice will be ciprofloxacin. The relapse rate and carrier rate is very less. So what is MDR strain? MDR strain is like whenever it is showing resistance to the older legs like chloramphenicol, ampicillin, to call it as an MDR strains. The MDR strains is they are resistant to the older legs, drugs like chloramphenicol and ampicillin. At that time, what will be the drug of choice? Again, it is going to be the ceftriaxone or azithromycin. So what is NAR strains? NAR strains is nalidixic acid resistant strains. So nalidixic acid is actually a quinolone, and therefore we cannot give quinolones when you are getting a nalidixic acid resistant strains. At that time, the drug of choice is going to be again ceftriaxone or azithromycin, or you can give ciprofloxacin in a 14 days. This is ceftriaxone, acetro, or ciprofloxacin in a higher dose. That is for nalidixic acid resistant strains. So, and again coming to the carriers, treatment of carriers is very, very important to control the spread of the infection, and so therefore the carrier has to be treated. The treatment of choice will be ciprofloxacin or ampicillin. Right? This is about the treatment part. We have to remember 3-4 drugs: ceftriaxone, azithromycin, and also the very important drug is ciprofloxacin. Do not forget ciprofloxacin. That will be the drug of choice when the organism is going to be fully susceptible. Yes, now we have almost come to the end of the lesson. So coming to the vaccines, so we have got 4 vaccines. This is the TAB vaccine which I have already discussed. Whenever the TAB vaccine is against Salmonella typhi, paratyphi A and paratyphi B. Because of more adverse side effects, this vaccine is no more used, no more available. So we have got 3 vaccines now. Typhoid VI, this is against the polysaccharide, capsular polysaccharide VI. Yes, and Typhoid, this is a live attenuated strain. The entire organism is attenuated. That is a Typhoid strain. You are going to give it orally. VI and capsular antigen you are going to give intramuscularly or subcutaneously. This will be like this polysaccharide antigen, which is a T cell independent antigen, and therefore you cannot give in children less than 2 years. So it can be given only in children more than 2 years, and the dosage you are going to give a single dose, and that will give a protection for 2 years. So after 2 years, again you have to give a repeat dose. Coming to the oral vaccine, it is a live attenuated strain or a mutated strain. That mutated strain will not actually multiply for a longer time. Once it is undergoing 5 or 7 divisions, it will actually self-destruct because of the lack of the enzyme UDP galactose epimerase. This enzyme will not be present in this organism, therefore it cannot go for multiplication of more than 5 or 7 times, and therefore it will self-destruct, and therefore it can actually produce only immunity, but it cannot cause any pathogenesis or infection. So the schedule will be on alternate days 1, 3, 5 and 7. So once you are taking this 4 doses, after 7 days you will have the immunity, and this immunity will be lasting for around 4 years. So again in the 5th year you are supposed to repeat the entire schedule. You cannot just give a single dose of booster vaccine. The entire schedule has to be repeated after 4 years. So that is about the Typhoid vaccine. And the last one is VI recombinant vaccine. This VI polysaccharide is going to be recombinant with Pseudomonas aerogenes or exotoxin A. That is why you call it as a recombinant vaccine. So we have discussed that the polysaccharide vaccine is a T cell independent antigen, so it cannot be given for the children less than 2 years. But this is a recombinant vaccine, which is a conjugate vaccine, and therefore we can give for children less than 2 years. So this is about the vaccines. We have got 3 vaccines: Typhoid VI, Typhoid, and VI recombinant vaccines.
Ma'am, you're muted, ma'am. Hello, ma'am, you're muted, ma'am.
Yes, am I audible?
Yes, ma'am.
Yes. So we have come to the end of the class. Yes, you have to remember certain things before leaving this. So the organism name is Salmonella typhi. It always starts with a capital letter because it is a serotype. So it starts with a capital letter. Then the pathogenesis is a bacteria-mediated endocytosis. And we have to remember the features, clinical features, step ladder pattern of fever, which is a remittent type of fever, and relative bradycardia, the Lieber-Mister stool you have to remember, and the altered bowel habits, alternating constipation and diarrhea. That you have to remember. And the laboratory investigations, one important thing which is very much correlating is eosinopenia. Since we are living in India where the parasitic infections is very common, we cannot see eosinopenia in almost all the patients, but whenever you are seeing eosinopenia, it always points towards typhoid. And then the cultures, laboratory investigation, the first week you can go for blood culture, and the second week you will go for WIDAL, and after that you will go for stool culture. And the treatment of choice, empirical treatment of choice will be ceftriaxone. But then whenever the organism is susceptible to almost all the antibiotics, so we are always supposed to shift to ciprofloxacin, since because the relapse rate is less than 2%, and also the recurrence rate is less than 2%. So that's all about this class. So if you have got any doubts, you can just ask.
Yes, ma'am. Thank you so much, ma'am. If anyone have any doubt, you can just post it in the comment section. So we had almost like 125 students attended this session. Thank you so much for attending. And if you have any doubt, you can just post it in the comments if now itself or after the class, so that we will inform ma'am and we will just get it clarified. Thank you, ma'am, so much for joining with us today. Hope we will be having more number of sessions and more number of participants in the upcoming days. Thank you so much, ma'am, and thank you once again all the audience. If you have any doubt, again, as ma'am told, you can just post it in the comments, or we will be sending you a feedback along with a doubt clearance form, so you can fill in that answer so that we will be getting it clarified from ma'am. Thank you so much, ma'am, for joining with us today.
Thank you so much.